Hi, my name is Monique Allman, and I'm a PA at Kelsey Siebel Clinic in Webster, Texas, and today I will be discussing contact dermatitis. We'll be looking at some of the mechanisms and things to recognize, as well as real-world management strategies. I have no disclosures. Our learning objectives today will help us to properly identify and manage patients with contact dermatitis by being able to classify types of contact dermatitis, recognizing the clinical features and pathogenesis, learning how to diagnose contact dermatitis through history, pattern recognition, and testing, learning about management and prevention of contact dermatitis, as well as being able to identify some pitfalls that can occur in the diagnosis as well as management of contact dermatitis. So we know that our skin plays a crucial role in protecting the body from various insults in the environment. So why is it important to know about contact dermatitis? Well, contact dermatitis is a very common skin condition that has a significant burden on a patient's quality of life and is estimated to affect about between 15 to 20% of the global population and accounts for about 4 to 7% of dermatology consultations. But as allergy providers, we know that we probably see just as many, if not more, of these patients because initially every rash is an allergy, right? So contact dermatitis is an inflammatory skin condition. It's caused by exposure of an outside substance, whether it's an irritant or allergen, that results in redness, itching, and sometimes vesicles and scaling. It is non-contagious and at times can be painful. It can occur within minutes or to a few days after exposure, and it commonly affects the skin in the area where the substance came into contact with the skin. And now we'll go into how we classify contact dermatitis. Dermatitis is classified as irritant, allergic, or phototoxic. Irritant contact dermatitis is the most common form, making up about 80% of cases. It's due to inflammation and cytotoxic effects from direct skin damage from the substance and is not immune mediated. Allergic contact dermatitis makes up about 20% of contact dermatitis cases and is triggered by a type 4 T cell mediated delayed hypersensitivity immune system reaction to a specific allergen and can even occur in very small amounts. It can also be triggered by systemic exposure, such as inhalation or ingestion of a contact allergen in an already sensitized individual. These reactions tend to be more widespread, and these reactions occur following re-exposure to an allergen. Then we have phototoxic contact dermatitis, which is a dermatitis that occurs due to a UV ray activation of an allergen or irritant. So we know what types of contact dermatitis there are, but what are the risk factors for our patients that we should be aware of? Most of these are going to be similar amongst all forms of contact dermatitis. I will give you a general overview at this time, but as we go throughout this talk, I will also highlight those that are more specific to classification of contact dermatitis. So the most important risk for contact dermatitis is going to be exposure to the irritant. This can occur at work or at home and includes things such as frequent hand washing with regular exposure to soaps, detergents, and solvents. Next, we have environmental factors that include humidity, temperature, and moisture. Environmental exposures can alter the transepidermal water loss in the skin and increase its sensitivity to substances, thereby contributing to contact dermatitis. For gender and age, female sex is listed as a contributing factor, but this is most likely thought to be due to greater exposure to irritants versus biological factors. Now, with age, the elderly tend to have skin that is thinner, less elastic, and more fragile. So therefore, the barrier function weakens and increases the risk of irritants. Infants have skin that are thin, sensitive, and highly reactive due to its high water contact, immature barrier function, and surface area relative to body weight, which makes them more prone to irritation, rashes, and allergic reactions. Then we have pre-existing skin barrier defects as a factor contributing to contact dermatitis, especially that seen in atopic dermatitis, which is considered the most important risk factor in developing hand eczema. Other factors are skin color, meaning the fair complexion tends to have more episodes of contact dermatitis, and then as well as social history with alcohol intake and tobacco use being listed. So let's discuss irritant contact dermatitis. This dermatitis occurs as a result of direct skin damage and is considered a multifactorial disorder that is influenced by physical and chemical properties of the irritants, host sensitivity factors, as well as environmental factors. The physiologic process of irritant contact dermatitis initially occurs through damage to the epidermal barrier by skin occlusion or by influence of chemical or physical irritant, which causes higher skin permeability and transepidermal water loss. This cytotoxicity stimulates keratinocytes to release cytokines, including interleukins IL-1 alpha, IL-1 beta, IL-6, and tumor necrosis factor alpha. IL-1 alpha and tumor necrosis factor alpha then act as primary signals for the release of pro-inflammatory chemokines that attract mononuclear and polymorphonuclear cells to the site of injury. In addition, the TNF-alpha stimulates the expression of intracellular adhesion molecule 1, ICAM, on keratinocytes, which promotes the infiltration of leukocytes into the epidermis, and CD44 then participates in transendothelial transition of inflammatory cells. Repeated exposure reduces the inflammatory skin response and stimulates cell proliferation and differentiation. When looking at acute versus chronic cases of irritant contact dermatitis, it was found that chronically irritated skin contained higher levels of IL-1 alpha, TNF-alpha, and IL-1 receptor antagonists compared to non-irritated skin. Irritant contact dermatitis, or ICD presentation, has what is known as decrescendo phenomenon, where the inflammatory rash peaks quickly and then gradually decreases over time. So using timing of a reaction is another way that we can classify ICD. There is acute ICD, which usually occurs within minutes of when the skin is exposed to a potent irritant. It is often a single exposure, such as with concentrated acids, strong alkalis, and solvents. Then there is subacute/delayed acute ICD, which is the most common form of ICD, where there is a delayed inflammatory response that is not visible until 8 to 24 hours after primary exposure. Due to this delay in exposure, it may lead to the misdiagnosis of allergic contact dermatitis, but allergic contact dermatitis has a crescendo phenomenon of appearance where the rash worsens despite removal of the offended agent, so this should help with distinguishing between the two. Then there is chronic irritant contact dermatitis, which results from repeated or prolonged low-grade exposure where the skin's protective barrier is damaged and leads to inflammation. So what are the clinical features that will help with determining if you have an acute versus chronic irritant contact dermatitis? Well, let's first remember that irritant contact dermatitis is caused by chemical or physical damage to the skin that does not involve the immune system. So in acute cases, the dermatitis appears rapidly and does not extend beyond the zones in contact with the chemical. It consists of erythema, scaling, vesicles, pustules, and erosions. You may also see macules or papules and sometimes blisters or bullous lesions. Acute contact dermatitis in the irritant form is classically non-pruritic, but more of a prickling or burning sensation that occurs. With chronic cases, the dermatitis develops slowly and is well demarcated, and the skin findings include erythema, vesicles, and dry skin that then lead to lichenification and then form into hyperkeratosis and chapping, and you get like fissuring of the skin, and even in some forms, especially of the hand, you can get disappearance of the fingerprints. This slide is a great overview of irritant contact dermatitis, going from the pathophysiology into the mechanism of action into the signs and symptoms that are associated with that. So you can see in the diagram that common occupational exposures such as housekeeping leading to an acute inflammatory response. Then you get the keratinocytes undergoing cytotoxic damage, which increases the neutrophil and cytokine release, which leads to some perivascular inflammation causing histamine release from mast cells, and this histamine causes local blood vessel dilation and increased blood flow to the area of the skin affected, which leads to the appearance of erythema. So this is a good diagram to have just for a general overview of the process and how it goes, and it's broken down into acute versus chronic. So within the classification of irritant contact dermatitis, there are also different forms that are often seen, which include frictional dermatitis that occurs with repeated frictional trauma and is characterized by hyperkeratosis and lichenification. Next, there is traumatic irritant contact dermatitis, which can occur after an acute injury or trauma, such as a burn or laceration. Then you have pustular dermatitis that occurs with exposures to oils, chlorinated aromatic hydrocarbons, and fluorinated compounds. Another form is steatotic irritant dermatitis, also known as winter eczema, and it occurs primarily in cooler climates during the winter. It leads to intensely itchy dry skin, scaling, and is commonly seen in the lower legs of elderly patients. The final form that we will review is airborne dermatitis, which results from exposure to irritants like floating dust, solvents, fiber, sprays, and is mainly seen in occupational settings. So we've been discussing some of the pathophysiology, some of the clinical factors and appearance things to be mindful of. But what are some of the common sources associated with irritant contact dermatitis? So we usually break them down into chemical versus physical irritants. Some of the most common chemical irritants include water, detergents, we have surfactants, solvents, oxidizing agents, acids, and alkalis. In regards to physical irritants, those can be metal, wood, the barbs or the sharp parts of plants, as well as paper, dust, and soil. Now we will look at allergic contact dermatitis and the important physiological changes and mechanisms of action associated with this form of contact dermatitis. Allergic contact dermatitis is a delayed hypersensitivity reaction that is triggered by an immune system reaction to a specific allergen. This can even occur in very small amounts. The allergen causes a delayed immune response that occurs in two phases. The first phase is sensitization. This occurs when an allergen activates the body's innate immunity, which causes inflammation and T cell activation. Then the second phase, called elicitation, occurs upon re-exposure of the allergens that bind to the skin protein, causing a T cell response in the immune system, which triggers inflammation. This usually appears 12 to 72 hours after exposure and often persists longer than an irritant. The clinical features of the skin associated with allergic contact dermatitis are based on timing of the reaction. During the acute phase, the skin is bright red and edematous and may have some clear vesicles or bullae present. And as these break, the skin weeps the fluid and it becomes exudative. During the subacute phase, there is a formulation of papules instead of vesicles, and there is less edema seen. Often dry scales can be seen. During the chronic phase, there is scaling, skin fissuring, and lichenification, and minimal edema is present at this time. Excoriations are often observed. This slide is an overview of the pathogenesis and clinical findings associated with allergic contact dermatitis. It starts with the allergen exposure, then to the sensitization, then elicitation phase, which triggers increased mast cells, eosinophils, and CD4 and CD8 T cells, and inflammatory cytokines. The CD8 T cells then cause loss of intracellular adhesion, giving this clinical findings of spongiosis, papules, vesicles in the acute phase, and scaling, lichenification, and excoriations chronically. So we talked about the pathogenesis and clinical findings associated with allergic contact dermatitis, but what are some of the major sources of exposure that trigger these reactions? Well, this graph highlights common exposures. It is an extensive list, but it is important as we are exposed to these substances in all areas of our lives, and even prescribe things to our patients that may cause them to develop an allergic contact dermatitis. Some of the growing areas of exposure occurring with the acrylites specifically, they're found in artificial nails, so females commonly can come in with those, but they also have increased use in continuous glucose monitoring devices, So you may be seeing increased issues in your diabetic patients. For healthcare workers, rubbers and adhesives are constant source of use, so we have a lot of contacts with those. But based on the list, you can also see how these exposures can lead to issues in a lot of occupations. It is mentioned that in the United States and Canada, some of the most common allergens are nickel, MCI-MI, and fragrance mix 1, to name a few. So now we'll segue into the risk factors for allergic contact dermatitis. We were just previously talking about the occupation with healthcare workers being in exposure to a lot of the allergens, but there's also chemical workers, hairdressers, mechanics, construction workers who have constant exposure to allergens. Age, previously we discussed, the risk increases as we age for allergic contact dermatitis. Having atopic dermatitis or irritant contact dermatitis, so something already messing with the barrier of the skin, increases someone's risk for allergic contact dermatitis. Gender, women develop more than men allergic contact dermatitis. Question if hormonal status, or is it just more exposure to common allergens like nickel with jewelry and things like that. And then skin phenotype. It's found that darker skin types are thought to have better epidermal barriers, thus lower permeability to the allergens. So people with fairer skin types tend to have more issues with allergic contact dermatitis. Now to the final classification of contact dermatitis that we will discuss for this talk. This is photocontact dermatitis. This form of contact dermatitis is caused by a combination of UV exposure with a topical agent. It is characterized by erythema, burning, and photodistributed lesions. It occurs from alteration of genes by UV rays that leads to coating of altered protein, and then that altered protein acts as the antigen. Okay, so there are two forms of photocontact dermatitis. These are phototoxic contact dermatitis and photoallergic contact dermatitis. Phototoxic contact dermatitis, similar to irritant contact dermatitis, is the mechanism is non-immunologic, and direct phototoxic reaction may be the first time that they are exposed, and there is no sensitization that is required. Whereas with photoallergic contact dermatitis, similar to allergic contact dermatitis, the mechanism is immune mediated and is a delayed type hypersensitivity reaction. It's delayed onset, usually 48 to 72 hours after light exposure, and you must have sensitization before that immune reaction can occur. So with phototoxic contact dermatitis, the pathway is that you have this photoreactive chemical applied to the skin topically or absorbed systemically. Then there's a UV light exposure that causes absorption of photons that leads to free radicals, and these free radicals cause direct oxidative damage to the skin cells, leading to erythema, edema, and bullous lesions. With photoallergic contact dermatitis, you have the photoreactive chemicals that bind to the skin proteins, and then a photoallergen develops. Then you have UV exposure that causes the photoallergen to be processed by antigen presenting cells to the T cells, and this triggers a delayed immune response, causing eczematous inflammation where you may see erythema, scaling, and vesicles. So now we know classifications of contact dermatitis, including the potential triggers, timing of onset, pathogenesis, and clinical findings. Now, how do we diagnose and manage these conditions? Well, first off, for all forms of contact dermatitis, history is key. Prompt recognition and targeted management can reduce symptoms and prevent recurrence. So complete medical history, including possible occupational history, is important as it can give a clue to the type of contact dermatitis and possible substances that could be contributing. For a diagnosis of irritant contact dermatitis, there is no routine diagnostic testing available because irritant contact dermatitis is a diagnosis of exclusion. Thorough history of the occupation and household exposures, focusing on the frequency, intensity, and duration of exposure to the skin, as well as the areas affected, is helpful. You also have to deal with physical and clinical examination. The pattern and distribution of the rash may play a key role in diagnosis. And remember, irritant contact dermatitis does not generally spread, so it starts at the site of the contact with the irritant. Patch testing is usually done, but it's not done to find a cause of the irritant contact dermatitis. It's done to exclude allergic contact dermatitis as a cause. Other techniques that they use are measurement of transepidermal water loss and or histopathology. These are less used techniques, and biopsy is often unable to differentiate between irritant and allergic contact dermatitis. So it's, it is what it is. Some people will do it, but not often in the clinical setting. Then there is a non-invasive technique to distinguish irritant contact from allergic contact dermatitis known as reflectance mode confocal microscopy, or RCM. This is a newer thing, but it's found mainly in experimental settings, so not something that'll be available day to day in the clinic. For diagnosis of allergic contact dermatitis, patch testing is your answer. Patch testing is indicated in any suspected case of allergic contact dermatitis. And Coleman said the greatest abuse of patch testing is failure to use the patch test. So some of the patients that you may see that should undergo patch testing include those with chronic itchy eczematous dermatitis, those with recalcitrant or persistent dermatitis, our atopic dermatitis patients that tend to fail treatments, those with like a systemic contact dermatitis, patients with facial dermatitis such as the eyelids, those with hand, leg, and foot dermatitis, are patients that have stasis dermatitis. They should undergo patch testing. And then you have your dermatitis with unusual distributions. Okay, now we're going to talk about patch testing. So epicutaneous patch testing is the gold standard method for the diagnosis of allergic contact dermatitis. It relies on type 4 hypersensitivity reaction and usually tests for the major classifications of common allergens, including fragrances, preservatives, excipients, rubber chemicals, textile dyes, topical medications, and metals and other biomedical device components. Testing must be coordinated well to ensure the patient is off systemic immunosuppressants that could cause false negatives. Also, it needs to be coordinated due to the length of the patch test and the inability of the area, which is usually the back, getting wet. So that means the patient is unable to shower or wash their hair during the time. Additionally, there are other forms of patch testing, such as special adhesive patches called thin chambers that allow small amounts of potential allergens to be applied to the skin that can be used. Okay, so now that we know our patient needs a patch test, which is the right patch test for our patient? So there are several different patch tests available. We have our screening patch tests, like the TRUE test, which is the thin layer rapid use epicutaneous test that tests for about 35 chemicals, but does miss some important antigens. However, the upside for that test is that it is approved for age 6 and up, so it's an option for our pediatric patients. Then we have our expanded patch tests, which include the North American Standard Series, that tests for about 70 or 80 allergens, and then the American Contact Dermatitis Society's Core Allergen Series, which tests for 80 allergens. You also have the opportunity to do testing based on someone's specific exposure or specific industry they may work. So if you have a female that has, a rash to her face and you're trying to figure out what she's allergic to, you may pick to do a cosmetic patch test, or if someone works with, um, you know, rubber, and you would do a rubber patch test. If someone may potentially have issues with metals, you may do a metal patch test. That's seen often with people as they're going to undergo surgeries and things like that when deciding which metals they should and should not use. So we'll talk a little bit more about the expanded patch testing. This includes allergen-based on the standard screening patch test, a true test. So it can increase the diagnostic yield and allow for additional allergens such as textile dyes. Um, and then there's also MCI, dimethylaminopropylamine, fragrance mix, shellac, hydroxymethylcrolate, the hydroperoxides of linalool, iodopropanol, propolis, carmine, propylene glycol, DMDM, ammonium persulfate, lauryl glucoside, sodium metabisulfite, ylang oil, formaldehyde resin, acrylates, tea tree oil, benzophenone, and then mixed dialkyl thioureas, to name a few. So with the expanded patch test, these are loaded. Preferably, it would be done right before, but you can preload the testing with those allergens that are in petroleum, but you cannot, you know, prepare your test the night before with all the allergens because the acrylates, fragrances, and all the allergens in aqueous vehicles would not be good. Okay, so additionally, when you think about deciding between the true test and your expanded patch test, there are some things that if you're looking for specific chemicals would tell you to lean one test over the other. So it's found that the true test tends to miss about 50% of fragrances, 62% of balsam of Peru, 56% of thiamine, but it is better for things such as nickel, whereas the fin misses 25% of nickel, 21% of neomycin, 28% of MCI-MI, and then it's found that the fin chest is better for formaldehyde. So these are just some things that you have to take into consideration when deciding which test is right for your patient. But there's no tests that are going to encompass all of the potential allergens. So you just have to decide on one, and then if it yields no results, that is helpful just as it is if it does yield some results. And just because you have one set of negative patch tests does not mean that you can't patch test again. So timing for patch testing. So after application, the patch must remain on the skin for 48 hours, and then the actual patch is removed for the initial measurement, and then it is kept off the skin, and a follow-up reading is scheduled for 48 hours later to detect delayed reactions. And in some cases, readings may be done up to 96 hours after the initial application, as seen with patch tests such as the metal patch testing. So now we've removed our patch and testing needs to be scored. So how is this testing of a patch scored? Well, there is a universal patch test scoring guide, meaning no matter what form of patch testing is done, all patch have the same scoring system. So you start off with 0 or a negative, which means there's no reaction at the testing site, or you can have a question mark, or considered a doubtful reaction, which means there's just some faint erythema, and it's generally all about the same, like a mild area. Sometimes this could be due to just poor occlusion or a Tate reaction, or even early reading. The patch was removed a little bit too soon. Then you have IR, which is an irritant reaction. This is seen as a discrete patchy erythema without any infiltration, and this can often occur within hours and is not immune mediated. It may be seen with toxic or irritating substances. Then we have our 1 plus, which is a weak reaction or weak positive. And this one is seen as erythema and or infiltration, sometimes with papules, but there's going to be no vesicles seen. Then there's 2 plus, which is a strong positive reaction, where you're going to see erythema, infiltration, papules, and discrete vesicles present. 3 plus, which is an extreme positive reaction, is when you have bullae present, or even sometimes ulcerations in coalescing vesicles. So depending on the number of tests that you're doing, you'll get each allergen with a reading. And based on that, you're able to give the patient sheets that will give them specific chemical names as well as types of products that have that chemical in it, which is definitely very helpful. All right, so now we're going to talk about photopatch testing. Photopatch testing is done in patients with suspected photocontact dermatitis where there is a photosensitizer that is suspected. The testing is done similarly to the original patch test, except for there are duplicate patches applied. And then after the patch is removed, before reading, half of or one set of the patches is exposed to UV to induce a reaction. So with this type of testing, patients who have dermatitis that is predominantly in exposed sites with or without a history of sunscreen reaction, those patients who have chronic actinic dermatitis, and any individual with a photosensitive eruption for which there is no obvious diagnosis should undergo the photopatch testing. This testing, due to its, UV exposure, should not be done on the air test area if it is active. So if there's active lash, we wait until the lash has been cleared undergoing this type of testing. So we know that all patients with suspected allergic contact dermatitis should undergo patch testing. So what are some of the pitfalls or concerns associated with patch testing? Well, patch testing remains the gold standard for diagnosis of allergic contact dermatitis, but there are several hazards that compromise accuracy, such as false negative results, which can be found in up to 30% of those patients tested and can result from inadequate allergen concentration, wrong vehicle being used, prior UV exposure, concomitant immunosuppressive therapy, such as being on more than 20 milligrams of prednisone a day, or failure to perform delayed readings. There's also false positive results that can arise from irritant concentrations, pressure reactions, or what we call the angry back or excited skin syndrome. False positive reactions with the excited skin syndrome are adjacent to the large true positive reactions. And is suspected when more than 5 reactions occur in close proximity. There's also pustular reactions, which are common in metals like nickel, that are frequently irritant reactions and should not be misinterpreted as positive. Delayed reactions or delayed readings, days 3 through 7 are essential. A weak reaction at day 7 is more likely clinically relevant than one at day 3. Testing only a baseline series may also miss relevant allergens. So supplemental series based on specific exposures and or the patient's own products should be included. So if patch testing cannot be performed or is inconclusive, but there is a strong clinical suspicion of allergic contact dermatitis to a leave-on personal care product, a rote or usage test can be performed. With this, the patient uses their own products and they apply a small amount of the suspected product twice daily to the inner arm just inferior to the antecubital fossa for up to 14 days to see if a skin reaction occurs. It is good because it allows the patient to test, their own products one at a time. And then it is a good option for those who may not be able to afford a patch test or are unmedically able to get off things like steroids or immunosuppressants that allow them to undergo patch testing. However, it is not appropriate for chemicals of unknown concentration or ingredients, such as those industrial chemicals. It must be recommended with caution for rinse-off products or soaps due to the risk of irritation. Some additional testing options for allergic contact dermatitis include immunologic tests, and then tests that investigate for the presence of allergen-specific T cells in the skin and/or blood, punch biopsy, and using immunohistochemistry to determine if T cells are present. These tests are not used frequently, but they are an option that may be seen more in the academic or research setting. So even without testing, there are clinical features that can help distinguish between irritant and contact dermatitis, such as location. Irritant usually affects the hands versus allergic, which affects exposed areas of the skin, which can also include the hands. Symptoms, burning, and pruritus, and pain with irritant versus mainly itching with allergic. Surface appearance with irritant is usually dry and fissured skin versus vesicles and bullae with allergic contact dermatitis. And then lesion borders. They're less distinct borders seen with irritant contact dermatitis versus distinct angles, lines, and borders seen with allergic contact dermatitis. In addition to some of the clinical features, the location of the rash can also help clue to a probable cause. As you can see with rashes that are more to the lateral side of the face, including the jaw and lateral aspect of the neck, are often found in products such as shampoos and conditioners that have rinsed down over those areas. And those involving the eyelids, upper and lower, is also usually seen in products such as shampoos and conditioners. When you have a reaction to the full face, those are seen in reactions that are either airborne, facial cleansers, or even makeup foundation. Rashes that deal with just the upper eyelid alone sometimes are considered to just be irritants, but those are the eyelids plus parts of the face are usually thought to be due to facial cleansers. Rashes that affect the forehead, eyelids plus the scalp are usually thought to be due to hair care products such as dyes, bleaching agents, setting lotions, gels, and mousses. When you have some combination of eyelids, face, and neck, we think sometimes about ectopic dermatitis from nail polish and acrylic nail dermatitis. This graph also just kind of does similar. It tells regional sites of contact dermatitis with common anatomical regions and associated allergens. So like I was saying before, scalp usually tends to be hair care products, bleaching agents, but can also be perfumes and preservatives depending on the substances is in those products. The face, neck, and back of hands, common causes tend to be fragrances, nickel, cobalt, lanolin, neomycin, or other type topical agents. But these areas are also areas that are prone to contact dermatitis because they're food exposed areas. When we talk about areas around the mouth, lips, and perioral region, we think of products that may have nickel, cobalt, fragrances, and topical medications. Rashes to the feet tend to be commonly caused by nickel, cobalt, fragrances, and occupational exposures. And those to the trunk can be fragrances, nickels, and occupational allergens. And those in the anogenital region tend to be fragrance, nickel, and topical products that are the cause. So what do we do to help manage the care of our patients that have been diagnosed with irritant contact dermatitis? Well, first, identification and avoidance of causative irritants is the most important. And depending on exposure, we'll have the patients wear protective equipment or protective gear if they have to actually handle an allergen. We apply emollients and moisturizers to help enhance the skin barrier function that has been disrupted, as well as like cold compresses and things like that for weeping lesions. To treat the irritant dermatitis, topical steroids are used sometimes in clinical practice along with emollients as adjunctive therapy, although topical steroids are not considered first-line removal of the allergen. Is the potency of the steroid use as well as um, the potency of the steroid use varies based on the severity and location of the dermatitis. And if a patient has secondary infection due to scratching, an antibiotic may be given, and oral antihistamines may be used if itching is a factor as needed. This slide is just a nice general overview of management of allergic contact dermatitis based on acute as well as chronic and severe cases. But I'll talk more about allergic contact dermatitis management on the next slide. So after a patient is diagnosed with a confirmed allergic contact dermatitis, we must educate the patient about allergen avoidance and remove the causative allergens. They're given handouts and information about the causative agents and products that those may be found in, and the patient is tasked with going through their household and occupational exposures to remove those culprits. Additionally, they are given resources to help identify allergen-free alternatives. And those can be, there's two major ones. There's a contact allergen management program from the American Contact Dermatitis Society, as well as the contact allergen replacement database from the Mayo Clinic, along with some other ones. And in this day of tech, there's lots of apps that can be used to help those patients identify which products they are safe to use. To help soothe the symptoms, they can use boro solution or cool water compresses. But we also have to start with skin protection. The barrier of the skin has been disrupted, so we need barrier creams as well as emollients to help repair. To treat the contact dermatitis, topical or oral corticosteroids are used for inflammation, and the potency is depending on the severity. In severe cases, such as those with plant or roost dermatitis, a lot of times those require extended steroid tapers that can be over 2 to 3 weeks, whereas a mild rash may only need a topical steroid for a couple of weeks. Or antihistamines are also used at times to help with itch relief. Patients that have phototoxic or photoallergic dermatitis have similar treatments as those for allergic contact dermatitis. So now we'll move on to differential diagnoses of contact dermatitis. So your patient has undergone patch testing, not much is showing up. What are some things that may look like contact dermatitis that your patient may have? So we have atopic dermatitis, dyshidrotic eczema, inverse psoriasis, a latex allergy, palmoplantar psoriasis, scabies, or tinea pedis. So we've done everything right. We've done the testing. We've diagnosed the patient with allergic contact dermatitis. So what are some pitfalls that can occur with contact dermatitis? Well, first you have patients, empirically change their personal care products, presuming that the persistence of the dermatitis means that the products discontinued were not causative, without realizing that the new product contains some of the same allergens as their previous products. So they're not using their camp or card management. There also can be that they don't give discontinuation of the product enough time to help improve the rash. Sometimes after removal of the irritant or allergen, it can take several weeks to a couple of months for things to clear up. Also, patients change the product at home, but then they maintain those same exposures at their workplaces or when they're off on vacation. They don't check the products that they use, and so they may be reactivating their allergic contact dermatitis. Additionally, after past tests, patients may forget or misidentify their triggers, leading to re-exposure. Patients have tolerated a product before and they assume it can't be the cause without realizing that they can develop new sensitivities, or there has been a product formulation change in a product that they've used for years. A manufacturer does not have to change the label on a product if it's minor changes. And so some of those preservatives or fragrances that may be in products, if they get a new bottle, may contain something that too. So sometimes these are things that continuously have people have their contact recur. So for contact dermatitis, here are some key reminders or takeaways. Remember that early identification of triggers and correct diagnostic testing, including photopatch testing when indicated, are essential to control symptoms and prevent recurrence. 2, combine targeted avoidance with symptomatic therapy and patient education to achieve durable management outcomes. And 3, remember that contact dermatitis is a great imitator, which can mimic many kinds of skin diseases such as atopic dermatitis, or can coexist with other skin disorders such as venous stasis dermatitis or seborrheic dermatitis. So here are my references that I use on the next 2 slides. And I want to say thank you for taking the time to listen to this presentation on contact dermatitis. If you have any questions, here is my contact information. Feel free to contact me. And y'all have a great day and an amazing conference.